Welcome to the Why Did I Get Cancer podcast. I'm Deborah Herlax-Enos, a small-town girl turned TV nutritionist and healthy living expert. I design health programs for the average guy or gal, including those average guys named Metallica. On September 1st, 2020, I was diagnosed with breast cancer. I asked every oncologist the same question, why did I get cancer? But none of my doctors had good answers for me. I wanted answers, and that's why I started this podcast. I want to help you to lower your cancer risk and provide self-care tips for those in the battle. I'm getting answers, and I want to share them with you. Okay, I know today's podcast is a little longer than normal, but I am telling you right now, it is so worth it. This is a recording I did with Dr. Corinne Menn. I know you've heard of her. If you're a woman and you're struggling with menopause or a positive sexual experience, you have heard of Dr. Corinne Menn. She is a menopause specialist. She's a breast cancer survivor and thriver. And she has been in the news a lot lately. And I'm so grateful to have had her on the podcast. The takeaways are huge. There's been so many. I'm going to do my best to just funnel it down to a few. First of all, she's an advocate for women when it comes to supplementing with estrogen if it's been not suggested for you by another doctor because of a breast cancer diagnosis or whatever it is. She is an advocate for women who've been forced into menopause through a breast cancer diagnosis or any other issue. And she talks about how little training most gynecologists have. Only when polled, only 7% of gynecologists feel comfortable talking to their female patients about menopause. That is not good news because when I was forced into menopause, one of my first appointments was with my gynecologist to say, hey, my body has changed dramatically. Help me. So if only 7% feel comfortable having that conversation, you have got to learn to become your own advocate. The other thing we talked about, which was so interesting, was that most breast cancer, she did say most women will survive breast cancer, and they don't end up, there's a few who die every year, obviously, from breast cancer, but most women end up dying from heart disease. And that is based on a lot of data, but also the fact that they went through some treatment that has been rough on their cardiovascular system. So that means they're gaining weight. Their metabolic activity in their body has changed. Again, the takeaways are huge. And we talk about sex. We talk a lot about sex. And we also had a conversation about why are women suffering so much in this area and nobody is listening. And I got to tell you, Dr. Menn is listening and she is preaching this message and it is good. She is well researched. She has stayed focused on reading the data and I really feel like she's in our corner. She's in my corner. So listen to today's episode. Again, it's a little bit longer than normal, but the payoffs are going to be huge. Pass it along to a girlfriend or pass it along to your husband when he's really struggling with understanding your menopause brain and your menopause body. Hope you enjoy it. Well, Dr. Menn, welcome to Why Did I Get Cancer? Dr. Corinne Menn is a board certified OBGYN. I think two of the other favorite things about her that I love, she is a long time breast cancer survivor and a menopause expert. So without further ado, Dr. Menn, welcome to Why Did I Get Cancer?
Thank you so much for having me. This is the space that I live in, that intersection between women's health, menopause, and cancer.
Yes. And you've been in the field for a long time. And did your own breast cancer journey, which we'd love to hear more about, did that kind of drive you into the menopause space as well?
Absolutely. I always say that, I was 28 years old when I was diagnosed with breast cancer. I was a second year OBGYN resident. It was 2001. And, went through menopause, not once, not twice, but as I always famously say it, 3 times, because the first 2 times were temporary due to treatment effects. And then the third time was when I had my ovaries removed prophylactically to lower my risk of ovarian cancer because I do carry the BRCA2 gene. And so, it was during that period of time, and that realization didn't come to me all at once because I was just kind of trying to get through cancer treatments. But eventually I realized like, wow, I'm not well equipped to take care of the average menopausal woman as a board certified OBGYN, much less somebody with breast cancer. I didn't know how to help myself, much less my patients dealing with average menopause. And so that's when I started to get involved with the North American Menopause Society, now called the Menopause Society, and did, additional professional education because OBGYNs are not trained in the management of menopause for the average patient. And recent stats, vary, but, roughly 7% of OBGYN family practice internal medicine doctors surveyed reported that they were comfortable managing menopausal women. And that is not a survey of, are they comfortable with cancer survivors who are menopause or premature menopause? This was just average menopause. So if we have that low level of confidence from the average healthcare professional,
right.
I always say sprinkle a little breast cancer and then you're like, forget it. No one wants to touch you.
Yeah.
And then on the other side of it is that, my oncology colleagues, and I'm so grateful to the oncologists who took care of me, and I got good care, and they gave me excellent shared decision-making on lots of things about my treatment, about maintaining my fertility, about, pregnancy after breast cancer, all of things which I did. But when it came to sexual health or premature menopause, collateral damages, they just didn't know what to do. And so it was actually never discussed. It's this pink elephant in the room that no one wants to talk about. And I don't blame them because if I was not trained in my residency as an OBGYN on how to deal with a normal physiologic function of women, menopause, we're all going to go through it at some point. Of course, the oncologists are not getting training. The internal medicine residencies don't have special sessions on menopause, right? So it's a real care vacuum.
Yeah.
It's a black hole, actually.
It is a black hole. And you're an OBGYN. I just assumed you would have had the training and that who else would we go to if you're not the expert? Who's going to help us with these hot flashes and night sweats and not sleeping and low libido?
Yeah. And the other thing is that, I think also part of the problem is that, it really shouldn't be delegated to only the OBGYNs. Like menopause impacts every cell of our body. We have estrogen, progesterone, testosterone receptors on, all the different organ systems. And so frankly, it's a real problem in the medical field in general that internal medicine doctors, rheumatologists, orthopedic surgeons, you name it, oncologists, every medical specialty, they need to understand physiologically what happens to their organ system that they study and they treat when a woman transitions to menopause, because there are profound physiologic changes. So then take that one step further and add on top of it being abrupt menopause or surgical or prematured or prolonged estrogen deprivation due to, medications like aromatase inhibitors and tamoxifen, which are important hallmarks of, backbones of treatment. No one's arguing that. But if we're doing a treatment, we must address the side effects of that treatment. And if it impacts your organ system that you're the expert on, you better damn well get yourself informed. And you can't just relegate it to the busy OBGYN who also was not trained. So we need to think of it a little bit more holistically because it's not just bikini medicine, right? It's beyond that.
Right. And I think about, I'm a certified nutritionist and I've had, years of training in the nutrition and health field. But when we think about physicians in general, I mean, how much nutrition training do you get? So it's kind of the same thing with menopause training.
100%. Yes. And, listen, it's okay. We don't have to be experts at everything. And so if I have a patient that I'm concerned about her nutrition, for whatever reason, I know there are credentialed, experts. And I have an obligation to know the basics. And I also have the obligation to know when I can send them to an expert. And so what I'm kind of asking and what us in the menopause space, we're asking is, listen, doctors, we know you're busy and you may not have been trained, but be a little bit humble and please just listen to your patients because they're suffering with sexual side effects and premature menopause side effects. And so if you don't know the answers, that's okay. Yeah. But please don't give her misinformation and don't dismiss her concerns. You could say, you know what? I don't know a lot about this, but give me a minute and I'm going to get you the resources because they are out there and there are experts. There's the Menopause Society in the US, there's the British Menopause Society in the UK. There are nonprofit groups, there are doctors like me out there who offer educational services to physicians and patients. There's a lot of resources. So it's, to me, it's no longer acceptable to just say, well, I wasn't trained, I don't know, here's an antidepressant and some lube. It's not okay. We need more than that.
We do. And that I went the antidepressant route because I was forced into menopause. I found out I had breast cancer on September 1st of 2020. And then by September 5th, I was forced into menopause with my first appointment because I was on hormone replacement therapy. And so they're like, absolutely not. You are done. So then I was dealing with cancer and then not sleeping. And just to be honest, no longer having sex with my husband because it was so painful. So I'm, losing my relationship. I mean, we're more than that. We're more than just sexual beings, but I'm just saying like that closeness, you lose that. You're dealing with the potential that you might have to do chemo and everything else.
Well, 100%. This is a great example of, we're often thinking about, the effects of, long-term, aromatase inhibitors or having your ovaries removed. But your case scenario is really, really common. So like the average menopausal woman, breast cancer happens, right? They're pulled off their HRT literally overnight. And then, so on top of that, think about trauma upon trauma. So suddenly you go from having your menopausal symptoms that were probably being quite well treated. You were sleeping, you were feeling good, your joints weren't hurting, you're doing all the good things. And then all of a sudden that's ripped away. You get nothing offered for you to replace that except for maybe an antidepressant, which we'll talk about. Well, that can be helpful, but can also cause problems. And then on top of that, the stress and trauma of a new breast cancer diagnosis. So I always say to myself, like, wow, like, how are we expecting these women to suddenly go from I have cancer and they have to navigate appointments, decisions, and at the same time we're causing abrupt insomnia and suffering. We really need to be a little bit more nuanced in how we, approach this. And I tell women it's not an emergency to stop your HRT. And, I know that's like a little bit of a bold statement, but not really. And let me give you an example. If you are 42 years old and you're still getting your periods and you're having, normal menstrual cycles, and then unfortunately you get diagnosed with DCIS or LCIS, precursor to cancer, or breast cancer, invasive breast cancer. Now you get that diagnosis and you go on to continue having your ovarian production while you navigate your breast surgeon and, all of your decision makings, MRIs, surgery, all this. And then at some point down the road, then you make a decision, okay, what am I going to do? Do I need adjuvant endocrine therapy? But we don't immediately, like the day after getting your abnormal biopsy results, put you on Lupron and shut you into menopause. There's a grace period of like, what is your treatment going to look like? But yet if a woman is newly diagnosed while on HRT, it is like the rug has to be ripped out from under her immediately. And I'm like, you know what? It's actually not an emergency. And yes, we will likely stop your HRT as we figure out what is your diagnosis, what are we going to need to do? But do we really need to abruptly pull them off? Could we taper them, let them stay on a little progesterone for a period of time and then slowly taper them off, get them on something, initiate vaginal estrogen because we know that that is safe. So that's just one example of how it really can be done in a much more humane way, frankly.
And let's emphasize humane. I tell you, it was abrupt and it was an emergency, even though I won't say it's not an emergency, but it seemed like it was such an emergency. Like you have to stop today. This is, doing XYZ to your body. And I just thought, oh my gosh, like I'm already dealing with so much. And now I'm going to get the dry. I used to have really dry eyes as well, which can be an estrogen thing. And so dry eyes, hot flashes, like, name a symptom. I feel like I had it all the while still navigating, working full time, being a parent,
doctor's appointments and very stressful decisions.
Right. Very, very stressful decisions. So I feel like the humane aspect was missing. And this was 4 years ago. So maybe things have changed.
They haven't. Because you know what, Deborah, it's because in general, women, society, doctors, they're really just taught that menopause is hot flashes and maybe vaginal dryness. Like
Yeah.
literally that. And so people say, well, what's the big deal? Like, all right, so you're going to have hot flashes. It's, all right. So, but they don't really look underneath the covers and realize like, no, there's a lot of things. It's not just hot flashes,
Right.
right? And so when we kind of like, don't even recognize what is physiologically happening, it's hard for doctors to even offer solutions or even be empathetic about it because they literally are not recognizing the full impact. And that's
Right.
that's a part of the problem.
Right. And if you think about it, a lack of sleep and that rest and digest, and when you're sleeping, that's when your body is clearing out the crap, the cells that have gone rogue, and so many other things. And if you're not sleeping, it's
Mhm.
setting you up for another health issue down the road.
Yeah. And so I always tell patients, like, you can have your cake and eat it too, meaning we can treat your breast cancer effectively. And
Hmm.
that may include for a period of time using adjuvant endocrine therapy if you're estrogen receptor positive. And, I am here to say, like, we can walk and chew gum at the same time. We can treat our breast cancer patients. We can offer them evidence-based options to help mitigate collateral damages of estrogen deprivation due to treatment.
Hmm.
And one of those ways we can easily mitigate one problem is when we can talk a little bit more about this separately is, the use of local low dose vaginal estrogen and vaginal hormones to treat the genitourinary syndrome of menopause. Because for goodness sakes, why would we not try to fix the things that at least we can fix, right? Even
Right.
if we're taking systemic estrogen off the table, either temporarily or permanently, that's not to say we can't talk about local vaginal estrogen. And we can also be very proactive about other ways, advice that we can help her navigate things from a non-hormonal standpoint. But women don't even get non-hormonal options. In the literature, when you look at surveys of patients, most patients report that less than half of patients, or a third of patients, 20% of patients, so a minority of patients are offered any help,
Hmm.
even non-hormonal.
Yeah.
So often the conversation, it's not just about HRT, it's about just addressing everything. And
Yeah.
just offering an antidepressant, that's not the only choice. There are other things out there.
Hmm.
But women get none of it, right? None of it.
Yes. And I felt like I got more instruction at the very beginning when I hadn't even been diagnosed. They took me into a separate room and said, "Hey, you have a bad mammo. Here's what breast cancer treatment looks like." And I got this whole, I don't know, 30 or 40-minute lecture. I was sobbing. And she said, "Why are you crying?" I said, "No, this is the first time I'm hearing I have breast cancer." And she said, "Oh, you don't have it. I'm just telling you, if you do, here's what's going to happen." And I thought, oh my gosh, we're going to make this big leap. And then like a week later, I did get diagnosed, but I didn't even get that kind of level of instruction about, hey, next up, hot flashes. But I feel like I just got thrown into the medical system.
Yeah.
Kind of the hook was set. So here's going to be your treatment, but there was not humane treatment.
Yeah. There's no
Yeah.
discussions of the collateral damages,
Right.
whether it's to hormonal health, sexual health, cardiac health, bone health, mental
Hmm.
health, none of that. All of the support, what I found personally, and it was 24 years ago. So obviously some things have changed for the better, but many things have not. I find most of the education that patients get is on the actual medications that they're taking, like what to expect after surgery, or, the chemotherapy. But it doesn't really extend beyond those survivorship issues or the other aspects of quality of life. Like that
Yeah.
stuff is relegated to like a side note, if at all.
Yeah.
And something has to change because the problem is that we have a growing army of survivors. Like most women survive their breast cancer, which is
Hmm.
wonderful. We have early detection, we have better treatments, but women are living longer with breast cancer. Even those
Hmm.
who have advanced disease or metastatic disease, who may not be cured of their breast cancer, but they're living a long time. We have a huge army of women with DCIS that has an excellent prognosis, right?
Mm-hmm.
Earlier stage. And so they're living longer, 4 million plus in the US alone, right? And we're not even counting all of these women now who, through genetic testing, are finding that they are, they are at a higher risk. So they may be doing things like having a prophylactic oophorectomy. So they're being plunged into menopause early, but because they carry a BRCA mutation or another mutation, they also kind of have an X on their back. No one knows how to deal with them, and they're afraid to touch them as well. And so there's just growing army of women, and it's not going to get smaller. When we have better treatments, women are going to be living longer and longer and longer. And so who's taking care of them? Who is taking care of their estrogen deficiency symptoms? Because that's what it is. And you know what? We don't have perfect answers, but we do have some answers. And women really need to be able to have shared decision-making, informed consent, true survivorship care, because we can't just treat cancer and just throw them to the wayside. You know, we can't, but that's what's happening. And when I ask patients, how much information did you get? Like, I got a pamphlet about sexual health, and it said, use lubricant and moisturizer. And I'm so that's not acceptable.
That's not acceptable when there's a solution.
We have very clear solutions. And so I like to point to the sexual health part of it, because obviously menopause after breast cancer is a lot more than just sexual health. But frankly, the sexual health collateral damage is actually something that we've got really good evidence-based care solutions for. And we actually have practice guidelines from the American Society of Clinical Oncology and from the Menopause Society and from ACOG. So this is not even controversial stuff here. Like, we actually have good solutions, but that is not getting out to women. And a good example was last year, I spoke to the Young Survival Coalition Annual Summit. It was about 400 women in the audience. And I was just talking about kind of these general ideas. And I just was like, so can you raise a hand, or how many people in the audience has ever heard of vaginal estrogen for breast cancer survivors, why it's important, what it treats, and what the genitourinary syndrome is? And it was like crickets. Like, there was silence. Like, the room was silent, like very few people. And after we had kind of explained what the data is, what the GSM actually is, and how it impacts, and the solutions, like, afterwards, women were coming up to me. They were crying. They were like, you understand? I haven't been able to have intimate relations with my partner, with my husband, with my wife, with my girlfriend, with my boyfriend, whoever, in years. It's broken up my relationship. I've gotten divorced because of it. Or I'm afraid. Or for young women, I was single at diagnosis, and now I'm afraid to re-enter the dating world because I don't think I'd be able to have sex.
Right.
And so how is that acceptable? That is cruel and unusual punishment to women.
It is cruel and unusual punishment. And I've just got to say, if this was a male issue, I think we'd be talking about it.
Well, we are, and we do. And I have a personal example of this. My father had early stage prostate cancer. He's great. He's doing fine. I went to his second doctor visit with him. And the very first thing, that the doctor brought up was like, well, this is what it is. We're going to have these treatments, but we really are going to prioritize your sexual health after this. And so I'm thinking, great, I need to sit here with my stepmother and my father.
This is a fun conversation.
But I was like, oh yeah, that is important. And wow, I'm so glad that they were being very proactive. And those men do suffer. I'm not making light of what men dealing with prostate cancer or other cancers are dealing with, but it is an integral part of the counseling. And I was shocked. I was like, oh my God, in the breast cancer world, this certainly does not come up. And the reality is these women are on much longer, prolonged hormone deprivation and have a lot, actually, I think, worse symptoms than men do. So, and the men are given lots of options and even shared decision-making about testosterone. They've got Viagra. They've got all different other things. It's prioritized.
It is prioritized, and they're talking about it. And is this a female thing to not talk about our sexual health?
Yes, it's gender inequity in healthcare, because we also don't get very much curriculum or training in sexual health in OBGYN residencies, and certainly not in any other medical specialty. If the OBGYNs aren't getting it, trust me, the other ones aren't getting it. And most of my sexual health information that I got as an OBGYN was about pregnancy prevention and STI, so sexually transmitted infection, treatment and prevention. That was our sexual health training. That's about prevention of pregnancy infections. That has nothing to do with sexual function.
Right.
So this is why it's really a problem of clinical education, right? And also, when I speak to breast cancer survivors, they feel a little ashamed to bring it up to their oncologist. One, they don't think the oncologist knows what to do. It's kind of, they feel embarrassed to bring it up, and they almost feel like it seems silly. It's not to bring up their sexual health concerns, because they should just be grateful that they're alive and that their doctor is treating their breast cancer. So, it kind of is like, in the big scheme of things, they don't know how to bring it up.
And maybe afraid to ask for too much.
Yeah.
Which is
and the reality is, listen, the oncologist is really busy dealing with a lot of, medical, issues with the patient. And so frankly, there's often not time, and they don't know what to do. And so it's avoided, because it's like, I don't ask, don't tell, because I don't even know what to tell you, and when they do tell them information, often it's wrong. I can't tell you literally I could have an Instagram account my only content would be vaginal estrogen, because there's so much misinformation in the average patient and in the breast cancer survivor. But, if anybody's listening to this, like, the take home is vaginal estrogen is safe for all women, including women in active treatment for any type of cancer, breast cancer, whether you're on tamoxifen, aromatase inhibitor, ER positive, ER negative, I don't care. There are local FDA approved, supported by the guidelines and the medical literature. Literally every other month, there's another study, a review article showing that it's extremely safe. Yet the majority of breast cancer survivors are either told they must first start with the moisturizer first and lube and only use it as last resort, which is ridiculous. Like, because then they say, this is the message, well, it's really safe, but we'd rather you start with something less effective that doesn't actually treat the genitourinary syndrome, menopause. And only after a couple of years of suffering, where your vagina has basically closed up, it feels like shards of glass, and your relationship is broken, then we can talk about shared decision-making about vaginal estrogen. And I'm like, really? So if you think it's safe to give at some point, why don't you give it preventatively, so that we don't have years of suffering?
Right. Because then there's another trauma. It's physical trauma, because it is like shards of glass. I've experienced that. And then it's mental trauma, and you're already dealing with finishing your breast cancer treatment or living with it or whatever it is. How much trauma? I mean, and then there goes your libido. Your mind is all these other places, physical pain, mental pain. Who wants to have an intimate relationship at that point? Anyway.
No. And there's also this lack of education that this one aspect of menopause is, it's also affecting your urinary health. So, with the lack of estrogen in the bladder and the urethra, what happens is the tissue quality is not as good. It's easier for bacteria to kind of crawl up the urethra. So UTIs are more frequent, but also urinary frequency and urgency. So I've had breast cancer survivors who are like, listen, my hot flashes I can deal with, or I've gotten over the hump, or I'm using some other non-hormonal medication to help me with the hot flashes, but I still wake up a couple of times a day to pee because of urgency. And I'm like, wow, people don't realize, if we just treat with vaginal estrogen and decrease that urinary urgency and frequency, it actually has this other side effect of, like, they're not woken up a million times at night. Right. So there's all of these little secondary things that we don't think about. And so that's why I'm like, if we could just ease a little bit of suffering, she might have a fighting chance at feeling a bit better. And the loss of intimacy is the other thing. Like, it's very hard to navigate this traumatic experience of being a breast cancer survivor if you're also now losing part of what keeps you connected to your partner.
Right.
And there's a lot of fear that the breast cancer survivor is disappointing her partner, that they're now broken and they're not as worthy as part of the relationship, because either it hurts to have sex or sex is just not pleasurable. So often patients will be like, well, with lube, it's not so bad. It's not, I can use lube and moisturizer, so it doesn't hurt, but it's not pleasurable anymore. Or they'll say my libido's really low. And I say, well, did anybody tell you that long-term use of an aromatase inhibitor causes clitoral atrophy or clitoral phimosis, where there's adhesions that grow over the clitoris? So sensation.
Really?
So touching of the clitoris, touching of the labia is just less pleasurable. Your brain is your biggest sex organ. So if your brain says, well, touching or physical contact is either it hurts, of course, that's a problem. But if it's just diminished, it just feels like, your brain isn't going to be motivated for
Right. It's not going to be motivated for at all. Right.
So certainly if it's painful, but even if it's just diminished or orgasm is harder, that is a negative feedback loop on your brain. So then your brain is like less motivated. So this also adds to libido, right?
Yeah.
So for me, like there's so many reasons why we can, just address just even the genitourinary syndrome of menopause. And that has far reaching impacts. It may allow a patient to actually stay on her tamoxifen or her aromatase inhibitor if we actually address this one simple thing.
Right.
Because in a survey of patients who stopped their adjuvant endocrine therapy, 40% of women cited that the lack of help with side effects was the main reason they stopped it. And one of the number one side effects are the sexual side effects.
Yeah. I am a new fan of copper peptides. I knew next to nothing about copper peptides about 5 months ago until I heard my friend Zora talking about them on her podcast. And she was saying how she'd had 2 hip surgeries, maybe 3 weeks apart. She applied copper peptide serum to one scar after she was healed, of course, but not to the other, just to kind of see which one, if it would work. And she said within a few weeks, she had to stop her experiment and start putting the copper peptide serum on both scars because she had such a dramatic response in the diminishing look of the scar. So that sold me because I got plenty of scars post-cancer, from my armpits to under my breast. And so I'm using it, but I'm also using it on my face because my skin changed post-cancer, removal of hormones and all the different things that my body went through. My skin was dry. It felt kind of rough. The skin just kind of felt like it was thinning and sagging. So I'm using the medical grade serum on my scars, but also on my skin. And I got to tell you, within a couple of weeks, my skin was smoother to the point where I'd say to somebody, touch my cheek. It feels so much better. So I'm a big fan, and I love the heart behind the product. Debbie Barber, the CEO of Vitali, she started this company when she was 64 because she'd experienced the value of copper peptides and just didn't want to gatekeep it. Like she knew it could change people's lives when your skin looks better, when your scars are diminished. I mean, I walk with a little bit more confidence when those things are happening for me. So she started this company at 64, which I also love. A new start, a new career as we get older. So if you're interested in these products, I've got a lot of information in the show notes, and they are offering my community 20% off, which if you go to their website, you're not going to get 20% off. They are offering it to me, which I'm so grateful. The code is Cancer Warrior for 20% off. But again, you can hit the link in the show notes. But I am telling you, these products are really great and I've really enjoyed them. And I'm telling everybody about them. I don't want to gatekeep them. Hope you enjoy them. It's time to start paying attention. And there is a solution. I've been on a vaginal estrogen since, probably 6 months into cancer treatment with surgeries. But I had to pay out of pocket to go to a naturopath oncologist. And so, so that's great. I have the money to pay for that. What about these women in lower socioeconomic areas who don't have, I'm in the health field. I was educated and I had money. So it worked out for me. But what about those women?
Yeah, so exactly. And so this is, again, not rocket science. It's pretty easy. Like vaginal estrogen is safe. The nurse practitioner, the PA who's working with the oncologist they could easily counsel and prescribe it. The average OBGYN does not need permission from the oncologist to prescribe something that is safe and effective. They can, of course, you want the health care team to all be on board and everybody be informed, yes. But what happens, I see, is this kind of cat and mouse game where the oncologist is like, go see your OBGYN about that. Then the OBGYN's like, well, I don't really know. You have ER-positive breast cancer. Why don't you just start with lube? And so then go talk to your oncologist. And then they've got to wait 6 months to get in, and they're basically caught in a catch-22. And I'm like, wait, please stop the madness. Can we at least
stop?
Address this?
Right.
So that's one example. But then we can also talk about the impacts of hot flashes, night sweats, mood changes, joint pain, all of the other things, heart palpitations, brain fog, changes in mood, cognition. Those things need to be taken seriously. And they, listen, we would love to be able to say like, hey, everybody go back on your HRT, and listen, that's a separate conversation about who can decide when they're done with treatment, if they decide to use HRT. But even if we're not talking about systemic hormones, there's a whole list of things that women can do proactively to help manage all of these things that don't involve taking hormones. A lot of it is, as a nutritionist, you probably know this, right? A lot of it is really specific counseling about nutrition, really specific counseling about exercise. But telling a breast cancer survivor who's in the midst of it, just eat healthy and exercise more, it's not enough because it's too broad. We need to be like, no, here's a prescription. I need you to, these are the things you need to start eating. You need to exercise. You need to start strength training. You need to understand you're about to lose skeletal muscle and bone mass. And you need to understand you're going to start gaining visceral fat. And your metabolic rate is going to get lower because you're not sleeping, and the loss of estrogen drives all of these things. It's a metabolic kind of change.
Perfect storm.
And, people are like, well, just give, well, if I don't have estrogen, I can't help that storm. That's not true. Yes, having estrogen is very helpful. But if you can't have it due to your treatments, there are so many ways we can hit that storm proactively, but we can't just tell women to just exercise and eat right without really good guidance. And the guidance isn't hard, but it needs to be written out like a prescription. Right?
Yeah, I can see how important that would be, because just telling somebody, well, go exercise a little bit more, do this, do that. Well, you're sleep deprived. You're getting up to pee 3 times a night. You're having 5 hot flashes, exercising more.
And your joints hurt.
Your joints hurt. Right. And your muscle recovery when you do work out isn't the same as it was 10 years ago. So, you're putting women at risk of more injuries, falls, like all these different things by just saying, okay, let's just go exercise a little bit more, add more cardio, add more of this. Well, how about we add more sleep? Because and really we can do other things.
Yeah. And I think that, and I get it, like the oncologist doesn't necessarily have time to go through all of that, but what they need to do is, we really need to, if you're an oncologist listening to this, or you're a patient who wants your team to do more, you need to basically say, okay, I get it that you don't know the answer to this, but I know I've self-educated that this, breast cancer treatments are going to affect every aspect of my body. It's not just about my breast cancer recurrence. It's about everything. And I need a referral to someone who really knows how I can maintain my skeletal muscle. I want to know how can I best help my cardiovascular health, because breast cancer survivors are more likely to die of cardiovascular disease than their breast cancer. Breast cancer treatments. Well, because the majority of breast cancer survivors will survive their disease. And I'm not minimizing the fact that there are women every year who die of breast cancer.
Of course.
Yes, women do. And women develop stage 4 breast cancer, which is not curable. But the vast majority of women do not. And so they go on to live a long life, perhaps, but their life might be shortened. And they're likely to die not of their breast cancer. Most early stage breast cancer patients are not dying of breast cancer. They're eventually dying of cardiovascular disease. Is the number one killer of all women is cardiovascular disease.
Right.
So breast cancer survivors aren't informed that their cardiovascular risk is higher than the average woman. Why? mainly because of treatment side effects. So early menopause, major risk factor for cardiovascular disease. Premature menopause prior to the age of 40, certainly 45, but certainly 40, or prolonged estrogen deprivation, very negative on cardiovascular health. Aromatase inhibitors in particular are negative.
Yeah.
Chest wall radiation adds to that. Herceptin adds to that. So if you take a Herceptin, anthracycline-based chemotherapy adds to that. Weight gain, depression, insomnia, severe vasomotor symptoms all seem to be associated with worse cardiovascular things. So when you take that all together, you can see it's like another perfect storm.
Right.
Now, it doesn't mean that if you don't have estrogen, we can't help that storm, but we better be a little bit more proactive. And so when I ask my breast cancer survivors who come to my educational sessions, or I have, they see me as a patient, I ask them, so has anyone looked at your cardiac health? Do you know your cholesterol? They did it a year or so ago. It's fine. Like there's no one's really doing a holistic look at what is her. And, I say, has anyone done a bone density? I am shocked that the minority of patients, and this is shocking because this is part of, it should be the care. They're not even looking at their bone health. They're like, oh, my doctor just told me to take vitamin D and get a little exercise, and they'll just keep an eye on it. And I'm like, you're 34. You have severe estrogen deprivation. You are at very high risk of osteoporosis.
Right.
And so if we can't give you back estrogen, we know we can at the very least be very proactive about your exercise and your nutrition. We can also offer you, there are medications, right? Bone specific medications to prevent further loss, but we can't just sit on our butts and wait until 10 years that you present with an osteoporotic fracture.
Right.
Because we know after a hip fracture, a third of women will be dead in the year after a hip fracture. And it's very debilitating. So we have to think a little bit more holistically about the long-term implications for these cancer survivors. So, we mentioned heart health, we mentioned bone health, we got into the sexual health part of it. The musculoskeletal syndrome of menopause is something that Dr. von der Wright just published an article on. She's an amazing orthopedic surgeon, and kind of just demonstrating through her review of the literature of that there is this syndrome that happens with the loss of estrogen. So guess what? Breast cancer survivors get the musculoskeletal syndrome of menopause earlier and in a more profound way.
Oh my goodness.
And so that syndrome is muscle loss, and bone loss, and the impact on joints. Right.
And metabolism and all the things. Yeah.
And so this is why you can't just be like, like hot flashes and a little vaginal dryness. Like, so coconut oil and an antidepressant are not going to fix the things that I just mentioned. Right. Which can seem overwhelming, but if you break them down in a logical way, we actually have actionable things we can do for all of those scenarios, right? You don't have to feel overwhelmed, because when you listen to this podcast, you might feel overwhelmed by all of those things. But I'm here to say, no, we can break them down and we can offer solutions, but it's not happening.
And these are not just solutions for women who've had breast cancer. I'm in a book club and it's all women. And maybe a year ago, I said something about my estrogen ring, which I'm sure my form of vaginal estrogen that my naturopath oncologist prescribed for me. And there were 10 women there and only one had ever heard of it. And I said,
right. Yes.
This will change your life. Like, ask next time, you call your doctor or go into the portal, please ask about this. If you want to, not experience dryness in the vagina, sex doesn't hurt anymore. I haven't had a bladder infection or urinary tract infection in forever. And it's really, for me, made a huge difference. And it made me so sad that none of these women had ever heard about it. And they kept saying, but you had cancer. And for me trying to explain, yes, but it's vaginal. There's great research. It's okay.
It is okay. And so you can put it in your resource link for this, but I actually, because I'm so tired of patients and women telling me like, no, but cancer. I said, no. We have lots of guidance. So I made a Google document and I just keep it updated. And every time a new study goes on, I add it. And it's literally, when you look at, I tell patients, take this, print it out. And if you want to go as far, print out every link in here. You will have an entire library, plop it on your oncologist's desk or your OBGYN's desk and say, I'm not leaving today without a prescription for vaginal estrogen, because if this amount of data in published literature is not enough for you, then I don't know what else to say, right? Because this is from ASCO, Menopause Society, OBGYN Society, in every, these are journal articles, literature that is peer reviewed, and we have decades of data on this. It is no longer acceptable to be telling breast cancer survivors they can't use local vaginal hormones. Yeah. So please share that link, because, patients really, I think when a doctor is presented with like, oh, okay, here's a document with like all these studies, it's like, it's actually embarrassing for them to say no. And if they still say no, then that's your sign you need a new doctor.
You need a new doctor. You need a new team. And Dr. Menn, it seems like we've demonized the word hormone. And does hormone equal malpractice? Does hormone equal lawsuit? Is this why doctors are so hung up on not prescribing?
Yes. Listen, as an OBGYN, I'm really very aware and cognizant of the fear of medical malpractice, because as OBGYNs, we're amongst the most sued physicians of all the specialties. Yep. And as an example, I tell this because it's a shock value, right? I practiced in New York State when I was doing full-time OBGYN, and I never had a lawsuit against me, and this was years ago when I was still doing obstetrical deliveries, right? For me to just walk in the door, I had to obviously have medical malpractice. My medical malpractice for OBGYN was $125,000 per year for me. So I had to pay $125,000 to an insurance company before I paid for any other expense, right? One malpractice suit, obviously you have your malpractice coverage, but that one malpractice suit could drag you through years of court cases, something on your record, it's very stressful. So doctors are extremely, fearful of lawsuits. Yeah. So when we have this world where we have now a breast cancer survivor who is asking for hormones, God forbid, for her vagina, honestly, the knee-jerk reaction is medical malpractice fear.
Yeah, I can understand that.
And that comes from the Women's Health Initiative from 2002, which created a lot of misinformation. And we learned a lot of good things. I don't like to totally vilify that study, because the Women's Health Initiative was a gazillion-dollar study, and we learned a lot of important things. The problem was it was mismessaged by the media. And
what a surprise.
And it was misinterpreted by the primary investigators. And that's a whole nother discussion. But it is what it is. But what it did is it vilified hormone therapy for the average menopausal women, and basically made everybody think it caused breast cancer and heart disease, which actually couldn't be further from the truth in either accounts, which that's a whole separate discussion. Now we've come full circle, and we know now, we've got very clear guidelines that we can't just use that mismessaging to counsel patients. And we know that the data is, for the vast majority of women, hormone therapy, the benefits far outweigh the risks for the average menopausal woman, right? But that fear that created this legacy of fear about the word estrogen, and it vilified it. It made it a dirty word. And so you take that, and then, you add on top of that for ER positive breast cancer, we do use anti-estrogens. We use tamoxifen, we use aromatase inhibitors. So that creates confusion. Well, if we're blocking receptors, estrogen must be bad, right? Right. And so I understand why people get confused by that. It's understandable, right? Yeah. But there's a little bit more nuance to that we have to explain to patients. But I think those things have made estrogen seem like a dirty word, and it shouldn't be. It's made women fear something that their bodies make and serve us very well through our years, right? Without estrogen, we couldn't have babies, we couldn't have breasts, we wouldn't develop as grown adult women, right? It's an important hormone, and testosterone is an important hormone too. It's a female hormone, but we've created a lot of fear around that, right?
Yeah, a lot of fear. And then it's just an easy default to think, well, I heard blah, blah, blah. And as you said, we're giving women all these drugs to, to suppress, that block estrogen. So, I can see how the conclusion would be so easily drawn that, well, why would I use that if I'm already taking this?
Yes.
It
Well,
just
so, and
it
yeah,
makes
and I
sense.
think so. Two like super simple points that I think it's really important for people to understand. One is estrogen receptor positive breast cancer. Okay, that's about
Hmm.
80% of the breast cancer that is diagnosed.
Hmm.
Um, Good news is estrogen receptor positive breast cancer tends to have a better prognosis, right? And generally is slower growing. But part of the treatment modality is to target those estrogen receptors. So people think that estrogen caused their breast cancer if they have ER positive breast cancer. So let's
Hmm.
just make this super clear. All normal breast cells have estrogen receptors. There are estrogen receptors on every cell of your body, from your brain to your gut, your bones, your muscles, and yes, your breasts, your bladder, everywhere else.
Yeah.
So that's in a normal, healthy breast cell. Okay. So, your 12-year-old daughter has estrogen receptors on her breasts, right?
Hmm.
So when you get estrogen receptor positive breast cancer, what that means is that your breast cancer, those cells developed, and for whatever reason, you got cancer, they became cancerous, and they still have the estrogen receptor on them. Okay. So they
Hmm.
kind of retain that estrogen receptor.
Right.
Estrogen receptor negative patients, right? Their normal healthy breast cells have estrogen receptors on it. When their cancer developed, their breast cancer, those cells basically don't express the estrogen receptor anymore. Those
Hmm.
cells tend to be ER negative breast cancer tends to be more aggressive. We call it often triple negative breast cancer. If they're also HER2 negative, tend to be rapidly growing, and they don't
Okay.
respond to manipulating the receptor. So I want women who have ER positive breast cancer to understand estrogen didn't cause your breast cancer just because it's ER positive.
Hmm.
But your cancer has estrogen receptors. So that's one way that your oncologist has a strategy to manipulate those cancer cells to do something to keep them from growing. And we manipulate cancer cells in a lot of ways, right? We give it chemo, we cut it out, we radiate it, so we burn it
Hmm.
out.
Yeah.
We can block receptors, whether it's ER receptors or if you carry the HER2 new overexpression, we can manipulate it with Herceptin. There's also these other things, we're doing now, immunotherapy. There's all these other new medications. So there's lots of ways we're manipulating it. And just because
Hmm.
it expresses the estrogen receptor does not mean that estrogen caused your breast cancer, number one.
Okay.
And
Hmm.
number two, women have to understand the difference between systemic hormone therapy and vaginal hormone therapy, two
Yeah.
totally different things. And I,
Yeah.
I did a reel recently where I said it's like you take Benadryl pill, right?
Hmm.
That you take as a pill and it makes you sleepy. And if you have a big allergic reaction in your body, it's going to help you, right? But you also can use a Benadryl cream, right?
Oh, yes.
That's the same thing. Or you take a prednisone, is a steroid pill that helps for lots of things, right? We use
Hmm.
steroids systemically, but we also over the counter get cortisone cream. That's a steroid cream.
Yeah.
And that's just topical. So it's like there's HRT, so systemic estrogen pills, patches, gels that are
Hmm.
FDA approved for hot flashes,
Yeah.
osteoporosis protection. That's very different from giving a little local vaginal estrogen cream. So that's how you have,
Great analogy. That
right?
is a great, and that's going to help me to explain it to girlfriends who
Yeah.
say, but you can't do estrogen or you can't.
No,
I
so
love
it's like
that. Yeah.
it's skincare. I say vaginal estrogen is skincare for down there, right? So it's
Hmm.
protecting the skin of vulva, vagina, but also the urethral kind of skin and the skin inside the bladder. And it's
Right.
staying where we apply it. It's staying
Yeah.
locally. So
Huh.
this is why it's safe, even if you have, breast cancer that you're being treated with tamoxifen risk blocking receptors or with an aromatase inhibitor, which lowers your systemic level of estrogen.
Yeah.
But you can still give back a little local level of estrogen just to where you're having the discomfort or the symptoms.
Right. And it will change your life
It'll
in
change
so
your
many
life.
ways. It'll change
Oh,
your
yeah.
life. So, as we're wrapping up, I know you're a 24-year breast cancer
Yeah.
survivor. What advice would you have given the 30-year-old Dr. Men?
Yeah. So, first of all, I did not do breast cancer survivorship well for many years because I was not educated myself. So, if I had to
Mm.
look back at my young self, I would have told her to take a deep breath and understand that the lifestyle pillars of health apply more to you than ever before, and that you have to make time out of your schedule and you have to advocate for yourself with your doctors about how you can implement nutrition, exercise, stress reduction, emotional health. That has to be prioritized. And it's just as important as your chemotherapy and as your cancer treatment. So when looking back, I was just, treading water and barely surviving, and I didn't make any time. So I really wish I would have doubled down on those things, right? Number one. And then the other thing is we've come a long way, baby, in 24 years.
Definitely.
And we have so many evidence-based solutions for dealing with menopause, sexual health, long-term survivorship care. They exist, but nobody's coming to save you, is what I'm going to tell you as well. And so you need to save yourself. And so you have to be the CEO of your survivorship, and your survivorship starts on day one of your diagnosis. So I know it's a big burden to ask you to have to self-educate, but honey, you got to self-educate, because I'm sorry, the medical community, we're catching up, but it's going to take a long time to teach old dogs new tricks. So what do? You have to self-educate, because an educated patient who goes in with the right questions is going to be the one who gets care. Where do you get that education? You can follow me. I've got lots of resources. A great source of information is menopauseandcancer.org. It's a nonprofit out of the UK, which has tremendous help for cancer survivors, all types, not just breast cancer survivors, on full survivorship care, including menopause and sexual health. I think that's one of my top sources of information, and start to plug in to, these resources, because, and keep a list of what is something that is bothering you that you want to work on. And I promise you, if we chip away at each little thing, we'll finally get to a place where you feel whole again. And we may not fix everything at once, but we can start to tackle all of your survivorship concerns. And you shouldn't make light of any of it. It's all important, right?
I love that, that you don't have to make light of any of it.
Yeah.
It's all important. And you're right. And it's okay to raise your hand and ask for help.
Yeah.
And
you can say, listen, I respectfully understand, doctor, that you may not know about this, but I'm also going to ask you for shared decision-making, and that this is important for me. It's as equally important as my breast cancer treatment. So if you don't know how to help my really serious sexual dysfunction that's been happened because of cancer treatments, then I'm sorry. I think you have a real medical responsibility to refer me to a qualified person who can help me. And there are qualified people out there. There's incredible sex therapists, there's pelvic floor physical therapists, there's sexual medicine trained physicians, there's menopause specialists, there's nutritionists, there's, exercise specialists who know how to help me. There's so many ways. So doctor, can you get yourself, a little referral network so that you can send me off? And if not, I'm going to have to find it myself, but I want you to be part of this team, because, I want you to treat the whole person here.
Great advice. I'm 4 years post, and I'm realizing I could have done a lot better, and I still can today. And it's never too late, because I'm still experiencing symptoms. And I think as women, we just get used to the symptoms, and we just get used to soldiering on, and we don't have to, because there's good research, there's good data, and there's people like you who are out there publishing Google documents with all of the research that we can then take to our oncology team or just a regular, GP and get some help.
Yeah. And even when it comes to hormone therapy after breast cancer, this is a discussion that there's a percentage of breast cancer survivors who want to have that discussion. They are grown ass women who can make informed decisions for themselves. And there is actually data and research that for some patients, it may be an option after you've completed your treatment. And just like we offer pregnancy, options and fertility preservation for breast cancer survivors, because we value a woman's reproductive capacity after breast cancer. Think about that.
Yeah.
Just let that sink in. Right now, New England Journal of Medicine just a year ago, published very, very important study, kind of really cementing the safety of pregnancy after breast cancer. And women can pause their tamoxifen or their aromatherapy or adjuvant endocrine therapy for up to 2 years to get pregnant, have IVF. So we value that, we allow it, we support it and celebrate it. But God forbid a long-term survivor wants vaginal estrogen or a small dose of an estrogen patch and progesterone, and suddenly it's heresy to bring it up. Give me a break. But I think we value a woman for her reproductive capacity, but we are not valuing survivors in their long-term sexual health and quality of life.
Right.
So we'll let you be a vessel for a baby, but we won't give you
let you have an orgasm. Yeah.
Give me a break. Now that's really where I really lose it.
Yeah, I really lose it there too. Yeah. Let's look at the whole picture, not just can you pop out a kid. So yeah. Okay, Dr. Menn, how does the whole world find you? Because we all need a Dr. Menn in our life.
So you could follow me on Instagram, where I post a lot of information, Dr. Menn, OBGYN, a lot of information about general menopause as well as breast cancer survivorship, number one. And the link in the bio there has a reference to that article on vaginal estrogen. I also teach a course for doctors who want to learn how to deal with menopause, hormone therapy questions, and in breast cancer survivors. And in a couple of weeks, I'm launching a course for the breast cancer survivor who just wants to kind of take this information in a more structured way so that they can be self-educated and advocate with their doctors. So look out for that.
Oh, I cannot wait for that.
Yeah. And I'm a medical advisor and a doctor for Alloy, which is a menopause telehealth platform for women. So it's great access for women who are looking for, menopause specialists to help them with their hormone therapy decision and options. And we do offer access to vaginal estrogen for breast cancer survivors and non-hormonal options for them as well. So that's a great source to check out.
And that's virtual. And so anybody
online clinic, and we've got doctors, me and my colleagues, we're in all 50 states. So whether it's me or with one of my really excellent OBGYN menopause specialist colleagues, it's a great source for general menopause care and access to hormone therapy for, women who are.
Oh, that's great. I wish I would have known you 4 years ago, but I know you now, and you're changing lives and bringing the specialness back to life because you're looking at the whole woman. And that just means so much to me. So thanks for sharing your wisdom. This was such a great recording. I cannot wait to go back and listen to it again. And thanks for joining me on Why Did I Get Cancer?
Well, thank you for having me and spreading the word and giving a platform for women to learn more.
Hey, y'all, can you do me a favor today and go and leave a review of this podcast? I know that the more great reviews, wink, wink, emphasis on great, reviews that I get, along with more downloads and more subscribers, that pushes this podcast out to people who might normally not even find it. And the reason I started this podcast and my real heart for starting this podcast is that I needed this information. It wasn't available. And so I started a podcast so that I could be a blessing to others. So you're a blessing to me just by being here. And again, thank you for your support. Thank you for your positive reviews and all of the notes that you send me. And also just want to say, hey, keep in mind, I'm not a doctor. And if you need medical advice, please reach out to your team. That is going to be just the best source for you because they know you. So again, I hope you enjoyed this podcast.